And as part of my, actually going all the way back to my undergraduate as well as my graduate training, was in electrophysiology with applications to study brain behavior work. And I worked with Bob Thatcher, helped to develop his clinical database a number of years ago as part of the applied neuroscience at University of Maryland, and did a number of publications with Bob at that time, and then also on and off during that time, and then subsequently I also did a lot of work with Roy John and his work in NYU, and helped to contribute to that database and some of those clinical operations. And then subsequently Roy John asked me, which I felt honored about, to be a partner of his in developing our BrainDX company, which we won't talk a lot about today, but maybe on another occasion. And of course, he passed away a few years ago, unfortunately, but I continue to work with his wife, Leslie Pritchett, and our other partners, and continuing that vision and that work. But a couple of years ago, Jim Evans had contacted me. As some of you may know, Jim has actually produced a series of books working through academic press on aspects of neurofeedback or applications of neurofeedback, and asked me if I wanted to share with him in putting together a book with my own brand of orientation on how we might use this or do it. So I said, sure, I'd be glad to, and that's what we did a few years ago. And then, of course, as most of us do when we put these books out, we reach out to our colleagues who are experts in the community and ask if they can participate. And there were a number of people I asked who couldn't, and other people who could, and other people, because they couldn't or had to drop out for other commitments, you know, Johnny come lately. But I think we came up with a fairly good group of authors in this book, Richard being one of them, of course, and we'll talk a little bit about that. But let me talk about what our goal was here. We really wanted in this book to have a different mission. A lot of the books that are out there are great books, and for many of you, I certainly would recommend a number of them. They are books written by various experts on how to do something, whether it's a particular set of protocols or methodology to apply for how you might treat depression or ADHD or what have you. There's some great how-to books. This is not really a how-to book. This is really what I wanted as a reference book, or as something closer to that anyway. So what I asked a lot of the authors to do, to as much as they could do within some constraints of what's out there in the literature, is to look through the literature and try to provide a sort of evidence-based model for which a practitioner can ask the question, I've got a case of such and such a type of clinical condition. There are a variety of neurotherapy techniques that I can employ or integrate into the care and treatment of this patient. What does the literature say about the utility or effectiveness of those current neurotherapy techniques that are out there? There's drawbacks about the literature in that it's, some of the studies that have been published are not the greatest, of course, and there are just in some certain clinical conditions, there just haven't been a whole lot of publications. But that's why I say, to the extent that they could survey the literature and make it available in a chapter in the book so that someone can say, I'd like to see what the latest and greatest or what generally the literature has to say about it. And in some cases, the authors may have sprinkled it with a little bit of, and by the way, among these things, this is what I use or prefer to use. But like I said, it really wasn't so much a how-to book. And the other thing that we wanted to do here was to provide an international perspective, because the way that we utilize neurotherapy or even think about neurotherapy of one sort or the other in this country is not necessarily the way that other people from other countries are doing it, or even thinking of using it, or may have restrictions about how they use it. So I wanted to, as much again as possible and reasonable, to include the input from people from different countries, again, who have had expertise in QEEG and other neurotherapy techniques to partake and have input in this process. And also importantly, while a number of other books out there do talk about methods of QEEG and neurotherapy and neurofeedback therapy in particular for certain clinical conditions or certain models, I really encourage people that if they wanted to, or to what extent, they can talk about how do you combine various forms of neurotherapy, or combine, for example, and we'll talk about this briefly with a couple of chapters, other things that step out of what we think about as neurotherapy, and that might include things like, nutritional therapies or vision therapies or other things. How do you potentially consider that information when doing neurofeedback therapy? So there's a few chapters in here where the authors specifically talk about that or show how they use other sets of information when they're doing neurofeedback therapy to, frankly, modify or temper the way that they're going to do the neurofeedback. So these are the main points of the mission of the book that's, I think, a little different than some of the other books out there, which may be good for some people and not necessarily well suited for others. So what I'm going to do in the approximate, time that we have left, and this is kind of, informal. I'm just going to, this is a large book. It's over 400 pages long, and there are about 16 chapters. I'm not here to talk about everything in detail. That's just not even practical, obviously. But my goal here is to try to step through selected highlights of points that are brought up in each chapter, some more so in other chapters that I think that are relevant. And by all means, any of you out there, if there's a particular point or question or concern as I talk about some of these things, again, I'm not the author of each of these chapters. I did have to obviously oversee what everybody was putting in and offer some editorial comment, so to speak, but I invite this to be interactive. I'm giving an overview of what's in the book, what's available to you that you might find useful or helpful, but I'm also interested in questions you might have about more detailed points or points of concern. So with that said, Chapter 1, I asked Corey Hammond, who many of you probably know, also has been very involved with neurofeedback for a very long time, to give a general overview of definitions, standard of care, and ethical considerations as an introductory chapter in the book to talk about neurotherapy. Now, we talk about neurotherapy. This is not just neurofeedback, but even in the general realm of neurofeedback, there are, of course, several types of neurofeedback methodologies. And so there are, again, I'm just telling you what's in the book, but I'm not going to go through all these things in detail. That's hopefully what you'll do if you find that you were interested in this information set. Neurofeedback, of course, is defined here as including the more traditional symptom-based protocols that were developed, frankly, before QEEG-guided methods came along. And then, of course, many of you are obviously very involved and are using, as part of what you do each week in these meetings, is talk about QEEG-guided data sets and deciding protocols and what works and what doesn't work. This may or may not include a live Z-score training, which some people are doing these days. And for those of you interested, I have a little mini lecture actually showing theoretically why live Z-score won't work or shouldn't work, even though it does work, at least in some cases. And there's a lot of discussion to be had about live Z-score training that Richard and I have shared back and forth, and I think we're of like mind on some of these issues. But I think it's an interesting discussion to have at some point. Loretta and brain avatar neurofeedback. Again, many of you are using forms of Loretta, or may soon to be if you're more of a beginner in the field, but there's many strengths about looking at Loretta information to make decisions about training. Low energy neurofeedback system, or LENS, is a system that certainly is near and dear to Corey's heart. And there are some people that use this and find it effective. Not as much literature behind it, but again, it's a system that people should know about. Slow cortical potentials is another neurofeedback mechanism that some of you may be aware of or know about. Again, growing interest with some of the slow cortical stuff has been kind of emergent over the last couple of years. That, along with infra low frequency neurofeedback, because these things are operating in the low frequency range, they potentially start tapping in a little bit more about its relationship to metabolism, which I know is a part of, obviously, what NewMind offers in their reports and things of that nature. So these are becoming of greater interest. HEG also looks at not direct neural activity, but really inferred activity from metabolism, like cerebral blood flow activity and oxygen saturation, principally in the frontal regions where this technique is developed. Very helpful technique. And again, so these things are sort of defined. If you're not familiar with the terms or the general techniques, they're defined in this first chapter. along with fMRI, which most of us don't use for lots of reasons, cost not being the least of which. And then there are brain stimulation techniques, and so again, Corey's listed most of the principal methods of what we call brain stimulation. These are not neurofeedback per se, what can be integrated with neurofeedback, and they're obviously what the intention is here is to directly stimulate the brain to move it in some direction that we're trying to optimize. Chapter 2 is Richard's book, chapter in the book. This is where I asked Richard to help provide a perspective on general QEEG, neurofeedback in particular. And so here Richard talked about general principles of database construction, the concerns when as part of that process, what the variance is and what we call normal. And there are lots of concerns about that, some of which I know is on this forum in the past. And then some more technical related issues in the process of using QEEG, which may have to do with amplifiers or other technical issues, not the least of which, of course, is artifact and other things. And then eventually the chapter moves toward, much like you do in these meetings, to talk about how to interpret basic maps and tables, how you might then integrate this into a formal QEEG report, and then, of course, use all this information for protocol selection for treatment and how you track it or follow it up. So these are sort of the key areas or key points that are provided in Richard's chapter in the book as an overview. Chapter 3 is one a little bit closer and nearer to my heart, and actually one that I really wanted to make sure we maybe even spent a little more time talking about today. This is by Lukáš Konopka, a long-term colleague. And
this is Sarah from Dr.
Hi, Sarah.
Office in Glenwood Springs. I was just calling because we have something open up next week on the 23rd in the morning, and I know we have you scheduled on the 2nd, so I thought maybe you'd want to
Hello?
You're good. You're good now, David. How timely that was. Someone's giving an appointment. You're talking about effective treatment.
Okay.
You're good.
All right. Yeah, so this was really Lukáš Konopka and Elizabeth Zimmerman, who are based out of Chicago, and Lukáš teaches or has taught quite a bit on psychopharmacology, as I do these days. So I asked him to honcho a chapter talking about medication issues, which, as you know, is a huge factor. And so you'll find lots of very useful information, I think, in this chapter, and I'm going to give you just a few highlights of what's in there. They do a nice schematic, presentation of all the conditions that hopefully any of us think about when we talk about successful neurofeedback. And many of these, are things that do come up, I know, in discussions on this forum. But these are issues that are brought up in this chapter, and also we'll talk about Jerry Gluck's chapter, who also talks about all the kind of things that can affect or interfere or that you should be aware of that can influence whether you're going to be successful in your neurofeedback practice or not. But specific more to medication issues, here you can see what he's done in the chapter is really divide, well, first of all, he took a limited set, and you can't cover every kind of medication in the world here, but he took the common classes of psychotropic medications that you see listed here, anxiolytics, stimulants, antidepressants, antipsychotics, and he wanted people to be aware of what to look for in terms of both the effects on the EEG. In other words, if someone comes in or is going to be taking a medication, some of the features that you may see that are initially indicated to be abnormal, could that be specifically a medication effect and have very little to do with the clinical symptoms or clinical disorder that the individual has? And that can shift and change depending on the duration of the use of these drugs. In other words, you may see acute effects from the initial utilization of the drug, and it can shift and change the QEG over the course of using this drug for months or even potentially years. So what to look for in terms of the EEG, but also what to look for in terms of what these drugs may do in terms of the symptom nature of the patient. In other words, how it's going to affect, or some of the symptoms may be a medication effect on terms of their cognition or behavior. And all of these things, again, having to have implications for the neurofeedback treatment protocol. So just a little outline is in here that many of you, when you do have a patient coming in on a medication, He steps through, they step through actually to kind of give you an idea of what you should be doing to make sure that you can help sort or sort of spread out the concerns of what medication is doing or not doing. So again, there's a sort of an outline, and I'm giving you just some bits and pieces of that here to recommend how you would deal with medication influences in making these decisions, as well as on the EEG side as well as on the behavioral side. So that you're going to find in the chapters, and then he'll give you, and I just listed a couple of tables really quick to give you an example of where he'll list the types of cognitive effects or side effects of the type of drugs, what the EEG effects are principally, and these are all referenced in the book chapter. He has all the scientific literature and stuff that backs this all up, of course. So this is an example for the benzodiazepines. This is the again, reported long-term effects as opposed to the acute. This is the acute effects of stimulants. Again, my purpose here is just to give you an idea of what's there, not that we'll actually spend a lot of discussion here, and so on. So again, these are some of the things available in that chapter. Chapter 4 is, as I mentioned, Jerry Gluck's chapter, which I thought was an excellent chapter. I really congratulated Jerry. This is not an easy task to do. He really tried to provide a global, if you will, encompassing many of the factors that can influence, again, the success or non-success of neurofeedback therapies or any of the neurotherapies. So he does talk a little bit about the awareness of genetics and gene factors and why you should at least have some rudimentary idea of what the family genetics of the individual are that you're treating. You should, of course, be aware of, as we've already mentioned, the drugs. Also, as that oftentimes comes up, is the issue of toxins, and part of the history of the patient, knowing what potential toxin exposures or risks may be as part of those factors, or why you need to potentially assess those issues, particularly if certain protocols are not working the way they should. And he also talks about hormones, which is another big factor we don't talk a lot about, but again, particularly with certain age groups, this is a very big issue. And so that's covered in this chapter. He talks about organic causes that are actually masked as psychological issues. There is a component in this chapter about nutrition, a much bigger component talked about in a later chapter by Jacques Duff, but he does review that as an issue. And then as a counseling therapist, somebody who, obviously, like many of you are licensed professional counselors, social workers, psychologists, what have you, what are the dynamics that can play into why the neurofeedback paradigm may not work? So he talks about some of the issues that go on in family dynamics, but also the patient's perspective themselves about what they think about therapy, how they see the interaction between them and their therapist, which is an often all too little discussed issue. And Jerry does a very good job in talking about this with a reasonable amount of input. He also, this is just a small example where he's using, in his example, some neuroguide maps to talk about pre and post on the influence of, in this case, it was hormones. This was a case of growth hormone. He's treating ADHD and ODD. This is a case of ADHD-ODD combination. And in the chapter, he steps you through the case of how, you look at the information, derive a protocol neurofeedback based on the QEEG, treat it. This is the changes you saw, and then he'll talk about the corresponding change in clinical outcome. In this case, largely where you see significant improvement with attention, not so much improvement with oppositional defiant. And of course, there's arguments why that is, or that may be the case. And he does this both with the sort of standard absolute power kinds of maps that we think about in linked ear kind of stuff, and then he also talks about it with Laplacian, where you're trying to sort through some of that. But that's one issue of what's going on that may, in this case, be, and he actually argues why this was being influenced by a growth hormone issue in this particular case that people weren't really thinking about, but played a role. And he has, of course, the data to show what changed and what didn't change in a variety of ways here. He talks about other factors that we talk about often, like sharp waves. If you don't look at the raw EEG, you're missing a good reason why occasionally you're not getting a good response clinically, or even a good response. If you're not aware what sharp waves or other abnormal proximal events are occurring with the EEG record before, during, after your whatever you're doing the patient, you're missing some very important reasons why your protocol may not be working as efficiently as it should. This is more about what I'm talking about in the dynamics. He looks at the concerns, how the patient, how you, as a therapist, in terms of the way you come across to the patient, concerns for the person versus concerns for the training. He actually has a matrix that talks about how this affects the overall effectiveness of biofeedback in general. And I think it's a chapter well worth for lots of practitioners to take a look at, because he actually talks about, and this is just one table of that, whether the person is being perceived or coming across as a buddy, and what your presentation as a therapist is versus the ultimate integrated practitioner, what are the challenges, what's the overall effect in the nutshell, and things to consider. So he really talks beyond just the technical things that we talk about in neurofeedback. It's also what you as a person, as a therapist, brings into that setting that also can influence the effectiveness overall of the neurofeedback that you're doing. Chapter 5 is by Lucas Caberta, a neurologist that I also work with occasionally, and I asked him to talk about developing evidence-based medicine treatment efficacy, talk about the concepts largely. And so what's great about Lucas's chapter is when you're reviewing the literature or you're looking at any neurotherapy technique, more and more, hopefully, particularly if you're going to be queried by naysayers or some of you that may get involved in forensics like I do, there are different levels of how well this is accepted or how strong a leg you're standing on supporting what you're doing. And so what Lucas does is provide to you different, what's called a 5-level, which is a pretty standard approach in defining evidence base in terms of, when you have a protocol or you have an approach, is this empirically supported? That, if not, you're out there on your own, baby. It's a level 1. Level 2 is possibly efficacious, and at least you can point to at least one study with sufficient statistical power, well-defined outcomes. Okay, level 3 obviously is where you've got more than one study. Observational studies have been published, both within subject and across subjects. Replications have been done. Ideally, though, you want to get to what's called a level 4 in anything that you're doing, where there's theoretically or hopefully there's been some good literature comparing this approach with a non-treatment group to show you that for the treatment or the condition you're treating, clearly it's well addressing that, and that there are parameters around the validity of how you're doing that. That's sort of the definitions of level 4. Ultimately, level 5, which is very rare overall, is not that this works well for treating attention, but specifically treats ADHD, and it's superior over something like medication or superior over talk therapy or something like. In other words, there's a comparison of therapeutic approaches when you're making evidence-based to say this approach really is not just good, it's adequate, it's efficacious, it's actually superior over other methods. And there are potentially some studies that will try to make that argument, and you should know about those studies. So he helps you define how you interpret the literature or interpret things that we come across all the time in the literature about what's really useful for us as frontline clinicians in potentially supporting why we're doing what we're doing, or again, sort of defending ourselves against the naysayers that are out there. Dagmar Timmers talks about his chapters specifically on treating ADHD. A lot of that, of course, I know you guys go through, and I'm not going to belabor. He just covers within that chapter a variety of neurotherapeutic approaches, which include, the utilization of medication, the history and effectiveness of the theta-beta approach, SMR training, of course, the QEEG-based and what's called phenotype-based protocols. Some of you may be more familiar with that than others. Again, the live Z-score training, slow cortical potential training, and more, and this was, of course, published in 2014, and it's continued. A lot of the authors talk about networks. I know networks are also discussed on this forum too, but Dagmar actually tries to decompose, as I do in my lectures, about there are different attention networks, and they involve different structures, and there's different. So when we talk about attention deficit disorder, I usually say we need to talk a little bit more detail about that. What does that mean in this particular case? Because there are different things that are involved and potentially different ways to go about treating it when we get to the nitty-gritty of the details about different attention networks that might be involved. Treating mood disorders, asked my long-term friend and colleague Emily Stevens, who has been doing neurofeedback for many, many, many years. to talk about mood disorders. And so she does provide an overview of the literature about neurofeedback, audiovisual entrainment techniques, which we did a publication together a number of years ago, CES and TMS and vagal nerve stimulation. These are, again, stimulation techniques and how effective they are independent of neurofeedback techniques per se. And so, again, you can go to the doctor and say, you know, what in terms of neurofeedback versus stimulation or variety stimulation literature have to say about how effective it is in treating things like principally depression, but obviously anxiety and other mood regulation issues. This is just a quick graph from that publication I talked about, where we did use audiovisual entrainment for refractory depressed patients who did not respond to medication or other forms of treatment. And what you're looking at here is there's two groups in a crossover design. One group, or both groups really start off, you see at baseline, this is from the Beck Depression Scale, very significant indications of depression on that scale before treatment. One treatment group starts in the first 4 weeks where they get audiovisual entrainment literally every day for 20 minutes at a low beta frequency rate to actually correct or entrain the beta that we're trying to get. The other group gets a sham procedure the first 4 weeks. And then at the changeover point, we're getting, which you don't see here, of course, we're getting QEEG information to show what brain changes took place or not, but also what's the clinical outcome. And you can see a huge improvement in the depressive symptoms. Again, these are 16 people who over the years have not responded to medication treatment and other forms of treatment. And then we do a crossover. These people now get the sham procedure. These people now get the audiovisual, and you can see that clearly the audiovisual entrainment technique is what's making or contributing to the change here. This group still had some residual improvement, minor, even without that, following the changeover to the sham procedure, but obviously the big significant impact was from the audiovisual entrainment. Chapter 8, I asked Carlos Novo to talk about head injury and applications in neurotherapy and what the literature has to say about cases treating closed head injury. There's two sections that Carlos divides this into. He talks about, let's just say, neuroimaging or methods of assessing brain function in two contexts when we deal with head injury. So he provides a discussion and a breakout just so that you're aware of everything out there. When we talk about traumatic brain injury of some sort, there are certainly structural techniques that we all know about that look at brain structure, not specifically function, and they're clustered up here. But when we talk about functional, we have our direct invasive techniques, non-invasive, and then some indirect techniques like neuropsych. And just so that you're aware of all of the types of tools or techniques that are out there when we deal with head injury. Many head injury patients come with some information in some or a variety of these. And, of course, EEG, QEEG, and other the electrophysiological ones are included in this discussion. And then he talks about these are the tools to define the nature of the head injury, and then there are tools that can be treating the nature of that. And that gets into his discussion more with QEEG neurofeedback, but he also talks about what's in the literature about RTMS methods to treat people with brain injury from head injury, and also deep brain stimulation, intracranial stimulation, which still goes on a fair degree and has something to say about how effective that is. So that's covered in that chapter. Thought disorders, Tanju Zermelli has been really, I helped to review his publication from a number of years ago in which he did a great study. If you have never read it, you really should, on the use of neurofeedback for treating schizophrenia. And I'm talking about long-term patients, that have been in treatment for years. Again, schizophrenia is not a condition that's easily treatable under any circumstance. But Tanju demonstrated that with neurofeedback, QEEGs more specifically, guided neurofeedback, he got tremendous results on a fairly large group of chronic schizophrenics who ultimately improved tremendously to the point that they no longer needed medication and actually remained in remission for their symptoms out to 3 years. So it's a very, very impressive demonstration of how neurofeedback can be very powerful in very significant degenerative disorders like schizophrenia. And so I've asked him to do this chapter, and he did a great job, again, reviewing the kinds of methods out there when you deal with thought disorders in general, types of conditions. So he reviews the literature for the QEEG neuroimaging, including Veretta and Loretta, the psychopharmacologic information, Again, a lot of the stimulation, in this case even encompassing ECT types of techniques, and then also compares computer-based training, and of course he favors neurofeedback or biofeedback methodologies in treating this population. This is just a snippet of the kind of things. Now what Tanju did for you when you look at this is he's actually listed to you, broke it down study by study over several pages of the key studies, I should say, who the authors were, what was the treatment type they used, how many cases were in their publication, inpatient or outpatient kinds of conditions, did they use control groups or not, how many sessions of treatment did they utilize in their protocols, what was ultimately the outcome. A great reference to actually show you in treating this population what's worked, what didn't work, and of course you can review through the literature. I just took one example, obviously, in here. There's several pages of this. But this is a great reference that I frankly find very helpful because it helps me also to say, well, so-and-so did this protocol, they did this. That protocol is not working for my patient with this condition, but who else did what and what else did they do and how effective? He breaks it all down for you in a more detailed way than I see in other cases. So that's available in that. He ultimately ends up showing how to use an evidence-based model approach in making decisions about neurofeedback protocols and which ones are more likely to work more than others because of the information that's available in this chapter. And he argues, of course, that among all the techniques that he reviews, and he does review a wide range of neurotherapy techniques in general, why neurofeedback is preferred, and he argues principally, this is a key point he makes, is that more so than a lot of the other techniques, neurofeedback allows you to be much more tailored to the individual in terms of specific parameters of brain function, specific regions. You can narrow these things down and make it much more tailored than some of the other techniques that don't allow you that degree of specificity. So that's what is in his chapter. The Dursons, I asked them to write a chapter on the applications to chronic pain patients. Again, they review much of the literature. They highlight their discussion mostly on the SMR training protocols and how effective they are. They also talk about, again, the literature, and that continues to grow and expand largely with network considerations and what structures within networks that we think are involved in pain. The chapter does a special emphasis on fibromyalgia. So there's a lot of referencing of what's in the literature and the issues of pitfalls and things when treating fibromyalgia syndrome. So that's covered in that chapter. Chapter 11 had a great group here working collaboratively on treating addiction disorders. And as many of you know, neurofeedback actually across addiction centers in the United States is built in as a standard method of treatment in addiction centers to varying degrees of what they do, and one can argue about whether those are the best protocols or not, but their addiction centers certainly embrace the idea that neurofeedback is a very important tool. And so I asked these guys to review protocols, so they do it from a historical perspective. Many of you know about the Penistone protocols, the Scott Kaiser modification of that, and again they review the literature showing the effectiveness of these protocols, what has worked or what hasn't worked. Again, a more general overview of the QEEG-guided neurofeedback methodologies when treating this population. What happens when you combine this with pharmacotherapy, which is, again, a nice supplement or follow-up from some of the more general issues talked about by the earlier chapter by Lukash and Elizabeth. And then special issues, specifically around the ADHD population that are, let's say, more at risk for drug abusing, and treatment protocols that have to be considered when dealing with that population. So that is covered in this chapter. Chapter 12 is the chapter by Barry Sterman and Linda Thompson, which I was really grateful that they would team up and produce this chapter. And I wanted a chapter particularly for neurologic-based issues, and so in this case seizure disorders, which as a neuropsychologist I see a fair amount of. Largely the focus in this chapter is, as you might expect with Barry being present, talking about SMR and the utilization of SMR neurofeedback. But they do a very good job in bringing in literature and support to what works, what doesn't work. They also do talk about slow cortical potential issues. Just to give you an idea, and I took an excerpt from this chapter that they wrote, so for those that can't see this real well, the data from these studies have been reviewed in meta-analysis by Sturman and Tan. In the Sturman review of 18 studies done between 1972 and 96, 5% of 174 patients became seizure-free, followed up for 1 year. 82% showed seizure reduction, greater than 30%, and an average reduction in seizure frequency of 50%. Tan and his colleagues reviewed 63 studies performed between 1970 and 2005, and that generally reported a reduction in seizure frequency in response to feedback training. 10 of these meet the criteria for inclusion in the meta-analysis. 9 of the studies increased SMR, and 1 trained down slow cortical potentials. In 64 out of 87 patients, 74%, there was a significant decrease, greater than 50%, in seizure incidence. In all of these studies, the subjects were treatment resistant, which is an important issue. These are studies that are demonstrating they're not getting a whole lot of benefit from their pharmacologic management of the seizure issues. And for any of you that know or have an opportunity ever to hear Rusty Turner talk, who is an epileptologist, neurologist, particularly working in the pediatric field, for many, many years, who's now become a convert over to neurofeedback. Rusty will be the first to tell you that in trying to manage seizures, he's been horribly disappointed by the efficacious or so-called efficacious nature of pharmacologic intervention. And personally for him, he has found that neurofeedback is a much better way to go, particularly in the populations that he serves, which is largely pediatric. But this chapter, and this is just a section to kind of show you the review and that they return, will give you information about in the review of these studies that have been done. Moving on, in Chapter 13, I asked a colleague of mine, Theresa Bailey, and I worked with her closely on this because it's obviously a little near and dear to my heart, how these methods are used for diagnosing and treating developmental disorders. And in that chapter, just to give you an idea, Theresa put her own, as people will do, her own spin on what she thinks is really important to do. She really emphasizes full cap information, obviously for acquisition. For people that are only doing smaller channel EEG acquisitions, that'll potentially help you, but obviously there's a whole lot of information that you're missing if you don't look at all the areas of the brain when you're making decisions. So this is just another excerpt that I took from that chapter, where she talks about how important full cap simultaneous QEEG acquisition in both resting and potentially test conditions appears to offer the best option among current technologies. And again, she reviews all the other technologies out there to document the functional state of the networks that may be involved in developmental disorders. If we think of behavioral and emotional symptoms as a final common pathway that can have a wide variety of causes and sources, purely symptom-based approach assumes a one-to-one behavior or emotion to location correspondence, and really that's missing and it's also making a lot of assumptions. It can miss the point. Doesn't really optimize treatment from her point of view. And again, you can read more about her arguments and support for those arguments, and ultimately in terms of effectiveness, and in this case, what she calls time and cost effectiveness. She also goes on to talk about, particularly with autism, and again, that's because of the issue that we've just talked about with seizures. This is another important reason why, if you don't carefully review all the EEG available out there, and even if you have some focal seizure activity going on in one part of the brain and that's not something you're even aware of, that's going to have a huge impact, again, on the success or the outcome of your neurofeedback protocol. So again, for those that may not see this real well, a special consideration for working with children on the autism spectrum is that approximately 30% or more may have a comorbid seizure disorder. Many more may be susceptible to seizures but not yet manifested or have areas of poor stabilization. So again, while in most cases there's no reason to think that a protocol in neurofeedback will induce or trigger a seizure, but it's out there. And certainly stimulation techniques is a no-no. I mean, in my book, you have to be very careful with stimulation techniques in this population because they're susceptible to seizures. And again, you want to use a full cap to identify what's really going on in different areas of the brain with these things. It's very important to get a really thorough and comprehensive evaluation, even if we are, and many of us do, and I do certainly, might do smaller selections of channels or regions as part of the training. We're not going to say try to treat everything at once, but you still need to have the 10,000-foot view, so to speak, of what's going on collectively, even if we're zoning in on only particular parts of the brain that we're interested in trying to train. And so this is a bigger issue, as I said, with this population, and also makes reference to a few others as well. But this is all covered in Theresa's chapter. These are the disorders that she covers in terms of pediatric issues or developmental issues in that chapter. The literature and techniques for general learning disorders, intellectual disabilities with or without seizures, reading and spelling disorders specific, that's different than general learning disorders, autism and autism spectrum issues, of course, developmental disorders, the general issue, but particularly with sleep disorders in pediatrics, which many of these kids do have significant problems with sleep that compound their behavior or their performance abilities. And also, which you don't see a lot of, is issues with things like enuresis, encopresis, constipation. What are the techniques that have been used or potentially can be used to treat that part of these pediatric conditions? So that's covered in there. Chapter 14 is the one that I mentioned earlier. Jacques Duff did a tremendous job, in my opinion, of nutrition for ADHD and autism. Jacques does not spend a lot of time talking about variety of neurotherapy techniques, because that's really covered in a lot of these earlier chapters. But more specifically, we'll talk about, as you know, that's often a topic on this forum, about nutrition, toxins, why you want to look at functional medicine kind of measures. And he emphasizes that point in this little excerpt. Our highly processed modern diet with its man-made trans fatty acids, chemical additives, preservatives, colorings, added hormones, antibiotics, is affecting a delicate balance in the nutrigenomic interactions and affecting our genome in general. Genetic weaknesses, which previously did not seem to affect us, now interact with the dietary nutritional deficiencies and environmental toxins to promote the modern diseases. It's not surprising that the rates of incidences of modern diseases such as cancer, diabetes, heart disease, ADHD, autism, depression, anxiety, irritable bowel syndrome, and inflammatory bowel disease, to name a few, continue to rise despite the billions of dollars spent on each year on research and pharmaceutical treatment, which for the most part are toxic to our genome and often carry unacceptable side effects. So this is a sort of this is the main theme of this chapter. And again, Jacques does a very good job in helping us all to understand a little more in detail of the interaction between important essential nutrients and metals like zinc or magnesium, certain vitamins, how they influence neurotransmitters, and where they play a role in this process, and obviously he integrates all of this into how this will affect brain function. And he'll give you a few examples of all of that. So again, a very good chapter for those of you that, and I think everyone should at least be aware of these factors that can influence or affect ultimately optimal outcome when we're trying to do neurofeedback. Chapter 5 was an interesting chapter because interesting in the sense you don't see this hardly ever. John Nash did an integrative chapter talking about vision therapy, which is very controversial. I stay on top of this all the time. There's a big controversy going on among neuropsychologists on this. But many of us know that vision therapy seems to work for a lot of kids in particular who have reading difficulties. It often is comorbid with other syndromes. And it talks about how it's a complement with forms of neurotherapy. So a large part of his point that he's making here is, as many of you know, Brodmann area 8, which is in the frontal field, frontal region, oftentimes called the frontal eye fields, plays an important role in regulating eye movement. So frankly, and I have data to back this, a high percentage, roughly about 80% of the ADHD population that we see in our clinic typically have weaknesses like reading and writing weaknesses, largely affected because of poor eye movement or eye control, movement control. These kids will pass an eye test in terms of acuity all day long, but when you really get down to measuring the subtleties of eye movement control that's involved in reading and writing tasks, it breaks down pretty quick in terms of how it applies in the classroom. And oftentimes when you do, and you often see, as you all know, with ADHD syndromes in particular, it largely involves frontal region dysfunction of one sort or the other, but particularly when it overlaps with areas like Brodmann area 8, you should suspect that probably to some degree these things are going to be affecting the vision system. And so he summarizes again that vision problems are common with ADHD and those with traumatic brain injury. Stroke can also cause eye movement impairment, affecting reading again. Apparently, there's been very little work examining the effects of brain injury on oculomotor function, although there's been literature to support it. And I see this, I did a lot of work in traumatic brain injury and myelin. Of course, that he's absolutely right. This is almost a common problem for people recovering from traumatic brain injury because there are disruptions in the visual tracking system, figure ground awareness, visual organization. As a neuropsychologist, we routinely assess if there are deficiencies in these areas of visual functioning because they play such a critical role in, particularly for kids, in terms of their educational success. But then we can correlate it back to our QEEG and our Loretta findings, and it helps the world become, arguably why we want to look at those regions in particular, because it's not just an attention. There are other things that are related to visual function that overlap with attention or even can result in problems with visual attention, but secondary to these issues. So this is kind of all reviewed in that chapter by John Nash. Again, a well-written chapter on a topic that's not well-known or a lot of people are not familiar with. Last but certainly not least is the chapter that I asked Tom Kalura to do, which was to kind of talk about future considerations. Where is the field of neurotherapy heading? What are some of the kind of conditions or issues that we might need to think about, because it's obviously a very dynamic field. There's more data coming through, modifications of techniques, new techniques being developed. So Tom provides a number of tables and discussion around concepts of neurotherapeutic interventions, ways to think about the way that we can potentially think about training in terms of operant learning or other forms like classical conditioning, not particularly operant learning. And again, some of the techniques that are involved in that way of thinking, of doing that, and what does this say about the future in terms of where these techniques can go to or what we need to think about in terms of their applications. So that is reviewed to a larger extent. One of the arguments that Tom makes here that I've taken an excerpt from, even if it's argued that the proper target is the population mean, in other words, we're thinking about Z-score training in this context, it does not follow that normalizing EEG is the solution to all the client's problems. A clean map is not necessarily the answer to a relevant clinical question. The EEG has deviated for a compendium of reasons, and simply setting it straight does not mean that everything is going to get solved. This point of view may be an adaptation of the pharmaceutical model to neurotherapy, but it does not address the core issues. Normalizing EEG does not cancel out the experiences or learning or cognitive or behavior dynamics that have happened, or necessarily all the physiological underpinnings that constitute that patient's condition. So what he's emphasizing here, which I think most of us do, is that while neurofeedback is a very useful, very powerful tool, it obviously is not the panacea to address all the issues that a client has or that the client brings into the situation. What I mean by bringing into the situation, a lot of the factors that Jerry Gluck's chapter talks about, or some of the other chapters, there's lots of things that come into play here. And the more that we keep an open mind and keep our eyes wide open to what all those factors are, the more likely it is that we can at least solve the problem about why certain neurofeedback protocols may or may not be working, because there's a lot of moving parts here. And also, we shouldn't necessarily be thinking, and I know Richard and Rob make this point frequently, that you necessarily have to normalize everything. Sometimes there are deviant measures that have developed over the years as compensatory mechanisms that actually serve a very strong purpose for being there. And we don't necessarily have to erode or break down those compensatory mechanisms. Maybe they get slightly modified, but we certainly don't need to try to normalize them. In some cases, that won't work anyway, particularly in traumatic brain injury. So when we talk about normalizing, what Tom tries to talk about is let's talk about what we mean by that and what's the implications of all of these techniques now and in the future, because it certainly speaks to what are we really trying to achieve as practitioners in using these techniques. So this is the kind of thing that's covered largely in that chapter. Last but not least, he talks about a further level of integration that will be available is that incorporating a lot of tools and other tests. And of course, we do that, and I know many of you do too. But it's very important to recognize that neurofeedback is to be integrated. And again, that's what I wanted is to come across in this book in general, is that we have a variety of tools, we have a variety of techniques. There's certainly plenty of room to integrate different techniques and methodologies and tools that are out there that we really should be considering, and not just on the feedback side, but also on the assessment side, as I've just emphasized. You obviously want to try to get as thorough and again, as much of the information to be clear about why something should work, and also how you track that it actually is working the way that you should. So he talks about it being integrated, a system that can put a participant through various mental exercises, evaluate performance, incorporate real-time brain activation, all important. When combined with localization-based, event-related types of monitoring, it becomes possible to create systems that literally see the brain in action, interact with it, produce a real-time assessment. You know, a lot of what we do is sort of post-hoc in a default mode kind of environment, but there's lots of information out there, and probably more in the future, that will actually see and help us modify brain function while it's actively involved in doing math, or involved in dealing with an emotional distress, or involved with that. And I can tell you firsthand that I am working in a research group right now where we are actually able to see the dynamics of brain function in an active emotional decision-making process that will, you know, change how in the immediate few seconds they're going to make a decision about how they're going to react to that. We have the tools to do that, and as we get more information about that, it becomes a very powerful tool, even in just standard counseling, marital counseling, couples counseling, whatever. When you can, in a sense, see what's going on in brain function, how it's affecting somebody emotionally, and part of what's going to happen in part of the decision network, there's decision systems that actually happen in the brain in real time. Now we get a real insight about how to modify and change that, and that's where, you know, a lot of the future may be. So that, folks, is an overview of the book, of what's in there and what kinds of information is available. And happy to take any questions or comments as we get pretty much here to the end of our hour. But I appreciate your indulgence and interest in finding out more about what's available in this text for you.
Well, David, let me first say thank you. That's just great. I have your book, and I agree with you. It's a great reference. It's one of those books you want to just keep on your shelf. So I encourage those that haven't gotten it to get a hold of it and take a good read of it. We do have a couple of minutes left, so let's see if anybody has any quick questions for you.
I will say that for those that wanted to know, the book is available through Amazon.com in a variety of forms. You can get it either as an electronic version, which is very inexpensive, that you can use on a Kindle, for example, as well as obviously in all the ways that Amazon provides any of its books in a variety of cost arrangements and different kinds of used or new or what have you. So I have found that, and you can order directly from the company, but frankly I would tell you that you're going to find it a lot cheaper and in a variety of ways through Amazon. So.
Okay. We're just waiting to see if anybody, feel free to speak up, anybody.
Would you post the picture of the book again? I need the title.
Sure. Let me move back to that for you.
Always glad to do
I
that.
promised to buy it.
Oh, it's Clinical Neurotherapy. If you on Amazon, if you just put in the search term Clinical Neurotherapy, you'll get this book and, of course, and others. But it's the quickest way to find it on Amazon.
Beautiful. Thank you.
Yeah,
Sure.
I can't emphasize the amount of work this takes to do for David to go and edit all these chapters and herd all of these busy cats into one bag. It's breathtaking that he was able to do it and finish the project. I've seen other people attempt to do it, and it just goes on endlessly for years, so you're to be applauded for that, David. I don't know how you did it.
And I got to tell you, it was originally supposed to be a one-year project, but it did turn out to be 18 months. And then people said even getting this done in 18 months was pretty amazing. And I have to agree. You're right, Richard. This is not an easy task for anyone to do. That's true.
It is not, David. I did the same thing in my old field, and it took us 3 years because we had all these international authors as well.
Right. Right.
So,
That's the other part. When you have, as you know, when you have international authors, there's a whole translation process. I mean, while they speak English, writing English and making it actually sound like it's supposed to, and the way there's another hurdle to come over. You know, so some of our foreign authors, that was also very time-consuming. So yeah.
And this is clearly one of the best. Well, this is one of the best comprehensive overviews of our field that I've seen to date, where we really get into all of the important details. And most of these people have all been in the trenches working at this for a long time, so they're not just speaking from an armchair, and that's really much appreciated too. Very much to all of us. Also opens your eyes to the complexity of our field and what variety is there if you haven't seen it. On the other hand, it can be overwhelming, and we just need to remind people that you don't have to know all of this. This is just a reference, and it's good to know as much as you can. We know you're all
or at least know what's out there.
Yep.
I mean, again, the purpose of this was just so that people are aware of what's out there, what you might want to think about, even if none of us use all of these things, of course, but it's good to know what's out there and what people have found that's helpful, so that you can always, pull up a reference and say, I need to find some articles on this. And even if you don't get into the chapters per se, the references alone in these chapters are just hugely useful for me. I can go and say, I got to find a publication that really talks to this or that. And
yeah.
Certainly for me is very helpful. So
I agree, absolutely.
Yeah.
That's when it's really important. If you're a writer, for sure.
Yeah.
We have any other comments here? Or?
David, that was a great presentation. I look forward to getting this book. I'm curious, on the slide where you had up to or around 30% or more of the autism spectrum may have seizure activity, and then you said we certainly wouldn't want to use stimulating therapies. Would you include the AVE or the photic stim in that category?
Yes. Yeah.
Okay.
I mean, anything that promotes an entrainment process. And obviously, you don't want to be trying to stimulate or entrain something that will, again, increase the risk for seizure. I'm very, very leery. To be honest with you, and we're an autism center, so we see a lot of autistic kids here. To date, I can't even remember the last time I tried a stimulation technique. I really try to stay away from that. There's just too many unknown things here. A lot of these kids have will have petit mal seizures that might be popping up only once or twice a week and will be completely under the radar. And my way of thinking, if I'm not really careful about what I'm trying to do or monitor with stimulation techniques, I can move that once in a while petit mal seizure that nobody even knew about, and it comes up as partial complex seizures all of a sudden out of nowhere, or even increasing the frequency of the petit mal seizures as a result of that. So I'm just saying it's one of those things that I'm just very leery about. I'm not saying it's not useful, don't get me wrong. I'm just saying there's that potential risk in there, and I try to be extremely conservative, at least from my point of view with it. So,
great, thank you.
All
David,
right.
Wayne Hewline, I just want to thank you for it's just an incredible contribution you've made to the field.
Well, thanks, Wayne. Appreciate that. Thank you.
All right. Well, David, thanks so much again for joining us. And we appreciate the time you've taken. I know you're a busy person, so thanks again. Have a great weekend, everybody, and we will see
you, everyone.
See you Monday night.